Well, good day, everybody, and welcome to the final Weber teleclass of 2025. My name's Martin Kinn, and it's my great pleasure to host the speaker who finished off the 2024 series of teleclasses just almost exactly a year ago. Our speaker today is Dr. Curtis Donskey. He works at the Louis Stokes Cleveland VA Medical Center in Cleveland, in Ohio. He is well known to everybody on teleclass education, as he has presented a number of teleclasses in the past, often focusing on topics around the environment. He's an ID physician. He's a researcher at the VA Medical Center. He's also a professor of medicine at Case Western Reserve University, and he chairs the Infection Control Committee for his sins at the VA Medical Center. Now, I mentioned his great work in the field of the environment, but today we're going to be talking about a different topic, and one that I don't think we talk about enough, which is empowering patients to prevent healthcare associated infection. So I'm very much looking forward to this, our final teleclass of the year. The floor is yours, Dr. Donskey.
Great, thank you very much for the introduction. My disclosures are at the bottom of the slide. They will not be pertinent to the discussion today. So let's start by imagining that you are admitted to the hospital. There are a lot of, our patient, as you can see, looks worried, and he should be, because there are lots of potential concerns where he could pick up an unwanted healthcare-associated pathogen. So in the hospital, providers may not always clean their hands. Environmental cleaning may not be done as well as it should be, particularly portable equipment. Even using the sink, you can be splattered with gram-negative bacteria. Procedures can be dangerous, and now we have to think about airborne transmission of organisms as well. So one common feature of all of the things that we do to try to protect our patients and prevent these infections is that we primarily focus on healthcare personnel. And much less attention has been given to patients. And so the objectives for today, I'd like to first identify areas where empowerment of patients could enhance infection control and antimicrobial stewardship efforts, review the evidence that patient empowerment interventions can improve infection control practices and potentially reduce HAIs, healthcare-associated infections, and then talk about how we might implement bundled measures that patients and families can use. And I would just point out that what I'll be talking about today, I did a review article 2 years ago on empowering patients to prevent HAIs. So a lot of, it needs to be updated at this point, but a lot of what I'm going to talk about today was covered in that review article. So why are patient empowerment initiatives needed? The bottom line is here, patients often do not appreciate the risk for healthcare-associated infections, and even if they do appreciate that, they do not always have adequate knowledge of actions that they can take to prevent infections. So I'm going to go through a number of issues where patient empowerment might be beneficial. So as we all know, the hands, the skin, and the clothing of colonized patients can transfer pathogens. This is a composite figure I made of a few studies we've done looking at transfer of MRSA, not from the hands or skin, but just from the clothing of patients. And we saw, so if you touch a patient's clothing with gloved hands, 60% of the time we acquired MRSA. When the patient sat down in their wheelchair, they transferred MRSA 50% of the time. Going to the lunchroom, cafeteria, or to physical therapy, about 30% of the time they transferred MRSA to surfaces from their clothing. And then somewhat surprisingly to us, we thought the elbow bump might be a good alternative to the handshake during the pandemic. And so we did a study looking at MRSA, and even a simple elbow bump, we transferred MRSA 15% of the time from the clothing of MRSA colonized patients. So although we know about these issues, hands, skin, and clothing are contaminated, patients who are colonized with these organisms don't always know that. But I think all of us who work in healthcare know that even though they may not be fully aware, patients are concerned. And so this is a common question that we get. are my family members at risk to acquire MRSA, or if I have C. diff, C. auris, VRE, from me when I go home? Will I give it to my grandchildren or to my immunocompromised elderly person in my household? Patients are very interested in knowing what they can do to prevent transfer at home, and also it makes sense that they would be interested in that in the healthcare setting. So let's go through a number of scenarios. Patients are often unaware of risks associated with devices, antibiotics, and procedures. So start with one example. Patients are not informed that urinary catheters increase the risk for urinary tract infection. This is a survey we did in 2012. 47% of patients said they had never heard anything about risk of UTI with a urinary catheter. Another survey at the University of Wisconsin, only 35% had said they'd received any information about that. And obviously, if they had received some information about that, they might be more keen to want to have that catheter removed as soon as it could be. And of course, patients, of course, are well aware that these things can be uncomfortable. And then here's another example. This is actually from my family. An 80-year-old woman develops bacteremia due to a PICC line, which was maintained unnecessarily for 3 weeks after completing some Rituxan therapy. Another example where if the patient were aware that this poses a high risk, they might ask, why do I still have this catheter? And in another survey from the University of Wisconsin, only 22% of patients with central lines recalled receiving any information from the provider that these pose a risk for infection. Next, patients are not aware that antibiotics pose a risk for C. difficile infection, or CDI. So here's one example. A healthy 35-year-old developed CDI after receiving clindamycin for a root canal. So one side point is that according to the dental guidelines, prophylaxis is not recommended for routine root canal procedures, and you should always avoid clindamycin, which is a major promoter of C. diff. But what our patient said, what she told me is, no one told me that I could get C. diff from clindamycin. And this is a common thing that I hear from patients who have C. diff. Nobody told me that there was a potential for an adverse effect. Next, patients are also not aware that oral hygiene may help reduce their risk for pneumonia. So the most common HAI is hospital-acquired pneumonia. The pathogenesis is oral colonization with subsequent aspiration down into the lungs. There's evidence that daily toothbrushing reduces the risk of hospital-acquired pneumonia. And that's strongest in the ICU, of course, where patients are on a ventilator, but also the data supports this outside of ICU settings. So obviously, this is something where we could do more to educate patients, and I'll come back to this point. So even when patients are aware of risks, they often receive inadequate instruction. So imagine a patient coming in for surgery who wants to do everything they can to prevent getting a surgical site infection. So here's a survey we did. 26% of surgical patients in our facility, when we quizzed them, did not receive instructions on chlorhexidine bathing. We did use this colorimetric assay to test for where chlorhexidine is present on their skin. And interestingly, we found that even when some patients didn't have chlorhexidine, but when you did have chlorhexidine detectable on skin, the neck was often being missed. And it turned out that our instructions were a bit unclear, and patients were interpreting them to mean you should start below your neck. And so a simple modification of the instructions was needed, and there are probably other examples like this as well. Education of patients with C. diff infection is suboptimal. So we did a survey with one other VA hospital, so 2 hospitals, and patients reported that only a minority of them reported receiving education on most topics. So how to clean your home, less than half. Only 62% said someone had told them they should wash their hands with soap and water rather than using hand sanitizer, which has no activity against spores. And really nobody talked to them about the fact that antibiotics are the primary risk factor for recurrence if you have an episode of C. diff. It's going to make it more likely that you'll develop a recurrence of infection. but almost nobody was told what to do if someone wants to prescribe an antibiotic. Again, I'll come back to that point. And then, when patients do receive education, sometimes it's suboptimal. So one thing that we found in our facility is that when we tell people to clean things with bleach, even our providers are confused sometimes about what products actually are sporicidal and which are not. And so I often, patients will often tell me they're cleaning yes, they're cleaning their household with bleach, but when you actually get into detail about what they're using, it actually is not a sporicidal product. And then, patients who do not have C. diff, who are being tested for C. diff, patients are not aware of when C. diff testing is indicated. So we conducted interviews of patients who had been tested for C. diff in our facility, and patients often said, when you asked them if they had diarrhea, they reported, yes, they did have diarrhea, and it was documented in the chart, but they didn't actually meet criteria for testing, which in the US, we typically say we should not be testing unless you have significant diarrhea, 3 or more unformed stools per day. And clearly, this is an area where education could empower patients to participate in efforts to reduce inappropriate C. difficile infection testing, which is now, there's a major push in US hospitals at least to try to reduce the amount of testing that we do on these patients who do not truly meet criteria for diarrhea. And then one of my favorite topics, hospital floors. So patients are not aware that hospital floors pose a risk for acquisition of pathogens. So we, in our facility, we have patients, we give patients these hospital socks, which are no-stick. They have a no-stick bottom, and patients walk on the floor with these stockings on. Here's a sock print showing all of the MRSA that this patient picked up on his socks after walking on the floor. And routinely in hospital culture surveys, floors are the most contaminated sites in healthcare facilities. And when we go around to hospital rooms, we often find things that people are touching in contact with the floor that they can then pick up and transfer to their hands. We did a study to really kind of define this a bit better in terms of how pathogens are acquired in the hospital. So what we did is we have our patient in the room, we cleaned the room so there are no organisms in there. We couldn't culture anything from any surface, so we did a very thorough, very well cleaned, disinfected room. And then we collected serial cultures in the room throughout the patient's 3 or 4 day hospital stay. And what we found is that as soon as patients moved into the room, as healthcare personnel walked into the room with their contaminated shoes, the floor rapidly became contaminated. And then the patient would then walk. So by day 1 or day 2, the patient is walking with his stocking feet through the contaminated organisms on the floor, and crawling back into bed. And then as we continued on, we saw that those same organisms that were on the floor were now on the socks, on the bedding, and we found it on patients' hands and on high-touch surfaces in their room. During this study, we showed that these organisms on the floor were the same as the ones that were acquired, that were on hands and on high-touch surfaces. We were never able to document during the study that portable equipment or personnel were contaminating these same sites with organisms, suggesting that the floor is really where a lot of these organisms are coming from, that patients are getting onto high-touch surfaces and onto their hands. So that's a long laundry list of potential areas where patient empowerment could be beneficial. There are a lot of things that patients could potentially do if we can identify effective interventions. So I'm going to turn now to the evidence that we have that patient empowerment interventions might actually improve infection control practices and potentially in some cases reduce HAIs. So early on, in terms of interventions to empower patients, Mary Ann McGuckin was a kind of a leader in this area. She developed the Partners in Your Care program, where patients were required or asked to, when personnel come in the room, you should ask them if they've washed their hands. And she had lots of good handouts to go along with this, and some evidence that these types of interventions can actually improve hand hygiene by healthcare personnel. There's an important caveat to this type of intervention. So we did an evaluation at the Cleveland VA, and we went in and talked to all of these patients, and a majority of them said they would be comfortable asking personnel, reminding them to wash their hands when they come in to see the patients. But then our research person, followed these same personnel around when they were actually seeing patients, and only 3% of them actually did remind personnel about hand hygiene. So patients are willing, but when they're suddenly confronted by a doctor or a nurse coming in the room, they either forget or they're focused on something else and not on patient hand hygiene. So what we did to try to get around that issue is we gave patients a sign that said, "Thank you for washing your hands," and 100% of patients were willing to display that as another way, kind of a nonverbal way to indicate that patients are interested in making sure that personnel clean their hands. And actually, I would just acknowledge that Mary Ann McGuckin, when she developed the Partners in Your Care program, had that as an option for patients who were too shy to ask personnel. She gave them nonverbal cues as well. Here's another. This is a study that just came out, number 3. They're in the healthcare system. They had a new kind of take on the empowerment of patients. They did anonymous monitoring. So they asked patients and visitors to have a checklist and monitor whether personnel were cleaning their hands without actually talking directly to them. And then in addition to improving personnel hand hygiene, there's also a lot of interest in having patients perform hand hygiene, since we think the hands are the most important source for picking up organisms and potentially ingesting them or otherwise acquiring them. Why don't we ask patients to do hand hygiene? And I put these references up just to indicate that this is not a new topic. I think some people think this just came around a few years ago, but back as early as 1983, Lawrence wrote a commentary on patient hand hygiene, and a number of articles in the early 2000s asked, is patient-centered hand hygiene the next step in infection prevention? And then in terms of interventions, I'll come back to these interventions, but the earliest interventions that I'm aware of, 2007 and 2010, people were already thinking about whether patient hand hygiene might actually be beneficial. So we all know that hand hygiene is very effective. This is an illustration of a provider who did an exam on a patient with MRSA, and you can see those hundreds of MRSA colonies acquired on hands. And then after using hand sanitizer, a good dose of hand sanitizer, those organisms were all eliminated. So hand hygiene can be very effective with alcohol hand sanitizer. I would just mention that when we've actually looked at MRSA patients, unlike personnel may have a transient pickup of some organisms on their hands, and patients with MRSA or other infections may have more, they may be part of their normal flora, and it may be a bit more difficult to completely eliminate these organisms. So with MRSA patients, we found 82% of MRSA patients had hand contamination with MRSA. That decreased to 40% with a single application of hand sanitizer. So the number of organisms was reduced, but we still had some contamination. So a single application is not enough for patients who are colonized. You need to have repeated applications. And then patient hand washing is also effective in reducing C. difficile spores. You can see many colonies on that plate on the left. And then after hand washing, you can see that there was a significant reduction, although not to zero. And so how many interventions have actually shown that patient hand hygiene may be beneficial in healthcare settings and actually impacting infection rate. So in the article that I review, in my review article from a couple of years ago, I had 13 or 14 articles total showing that interventions can increase the rate of patient hand hygiene and improve actual practice of hand hygiene. So these studies focus on actual outcomes where they try to look at reduction in infections. So the first study from Vincent Cheng and his group in Taiwan, it does a lot of very impressive work there in infection prevention. They noticed a lot of respiratory virus outbreaks on their psychiatry unit. And so he had employees assist patients with hand hygiene, with alcohol, hand sanitizer, and saw a dramatic reduction in respiratory virus outbreaks in the following year. In a Canadian hospital, they did patient and visitor hand hygiene. They actually hired some people whose job was to facilitate hand hygiene, and saw a 51% reduction in healthcare associated MRSA. 3 and 4 are a couple of small randomized trials we did at the VA. In one study, we saw reduced acquisition of pathogens on hands. Only 2% of patients who were doing regular hand sanitizer use had detectable pathogens on their hands during their course of admission, versus 35% of patients who were not doing the hand sanitizer intervention. However, we did note in the follow-up study in number 4, that type of intervention did not actually decrease acquisition of pathogen colonization when we were looking at acquisition of rectal colonization with organisms. Here are 5 more studies looking at potential benefits. So again, from Taiwan, Dr. Cheng's group, they used a patient hand hygiene in response to outbreaks of VRE in their network, and saw control of the VRE outbreak. In number 6, this is a study, a patient hand hygiene intervention focused on hand washing of patients to reduce the risk for C. diff, and they saw a reduction in healthcare-associated CDI after implementing that intervention. And then just published in a children's hospital. In this study, they didn't look particularly at infections, but did do a cluster randomized trial and showed that they could increase patient and visitor hand hygiene when frontline staff were involved. So it was really important to get staff involved in facilitating hand hygiene by patients. So what types of interventions are needed to improve patient hand hygiene? So I think the good news is that very simple interventions can be effective in increasing patient hand hygiene. So we developed a 4 moments for patient hand hygiene educational intervention in the VA, where we have these posters. We recommend hand hygiene before and after touching wounds and devices, before eating, after using the restroom, and whenever you enter or leave your room. And with this intervention, to basically a simple educational intervention, giving people flyers with a brief education in person, we saw an improvement in hand hygiene. And it's also, as I mentioned previously, having healthcare staff facilitate hand hygiene, it can be very important for patients. So as part of this intervention, we had food delivery personnel would remind patients as they dropped off their trays, don't forget to perform hand hygiene, and we're providing patients with a hand sanitizing wipe. And then transport personnel, we asked transport personnel, when they took patients out for appointments, they would have them do hand hygiene on leaving their room and again on returning to the room. So again, that we thought was very important as a way to facilitate and make sure patients are doing hand hygiene. And then, patients can also model hand hygiene for personnel. So we came up with a 5th moment for patient hand hygiene. And this was basically inspired by the fact that we found it was really not feasible in our facility for patients to ask personnel, did you wash your hands, or even thank them for washing their hands routinely, to say something. So we did think that we asked, what if we, instead of having the patients say something to the person, which they might not be comfortable doing. We said, well, when somebody comes into your room, we gave them a bottle of hand sanitizer and said, use the hand sanitizer whenever somebody enters your room, which gets you used to doing hand hygiene and signals to them that you are somebody who's very interested in making sure that hand hygiene is being performed. And then in terms of interventions as well, this was an intervention. We did an intervention to improve mealtime hand hygiene among long-term care facility residents. We're on very low rates of hand hygiene. And one thing that we do for all these patients, we put this little packet of a little towelette like you'd get in an airplane for the patient to use to clean their hands. And a lot of patients are not even aware that they're on their tray. They're on every meal tray. And even if they are, they have difficulty using those little packets. So this is actually from a video we made where we had this patient who had arthritis and some difficulty using his hands. It took him almost 2 minutes to open up and use this little towelette that we had. So the intervention really was to make hand sanitizer much more readily available. So we had a hand sanitizer stand at the entrance to the lunchroom area, and also put bottles of hand sanitizer on the tables where the folks were sitting. And then finally, we actually had champions among the long-term care facility actual residents. So residents would assist others who needed help doing hand hygiene. And this was very effective in improving hand hygiene. And then final point on patient hand hygiene, in addition to patients, visitors coming into the hospital also, it's important for them to do hand hygiene. So we developed the 4 moments for healthcare facility visitor hand hygiene, and this was a poster related to that, recommending hand hygiene when you enter the building so you're not bringing something in, after touching shared items in the facility, when entering and exiting the patient you're visiting's room, and then when exiting the facility. In addition, and as I mentioned, in addition to hands, patients have organisms. When you are infected with C. diff or MRSA or Candida auris, those organisms are not just on your hands, they're all over on your skin and on your clothing. So patients showering can be effective in reducing C. diff spores on skin. We recommend when our patients have C. diff, MRSA, that they do very thorough showering and bathing every day when that's feasible, and you can reduce the burden of organisms on your skin by doing just a general shower with good bathing. And then coming back to floors, we hypothesized that we see a lot of transfer of organisms from floors from the stocking feet as patients are walking through very contaminated areas on the floor. So we hypothesized that if we had patients slip on a pair of slippers whenever they step out of their room, whenever they slip out of bed, I should say. So instead of standing on the floor, they immediately slip on their slippers, placing them right next to the bed, wear their slippers when they're walking on the floor, and then slip them off before they get back into bed, that might reduce the risk for transfer of organisms to bedding and to high-touch surfaces. And so we modeled this by using bacteriophage MS2, which is a very benign virus. And so we put a big amount of this on the floor in between the patient's bed and the bathroom. And as you can see, when patients were just wearing the hospital socks, there was a lot of transfer of bacteriophage MS2 to the bedding, to high-touch surfaces, to personal items, and to hands. When those patients wore slippers, when patients were randomized to the slipper group, there was a dramatic reduction in contamination with bacteriophage MS2. And so, if you're admitted to the hospital, this is something that would be very simple that could be done to reduce the risk that you're going to pick up organisms from the floor and get them onto high-touch surfaces and onto your hands. And then oral care, as we mentioned, is very important, we think, to prevent pneumonia, and a very simple measure that patients can do. So the VA, where I work, the Department of Veterans Affairs, has a national program where they try to assist veterans with oral care during their hospital stay to prevent pneumonia. And they try to make this fun. Here's someone dressed up as a giant tube of toothpaste, and put out educational materials. And this has been a very effective intervention in the hospital. Really, the goal is to try to get the nursing staff to educate patients and to facilitate oral hygiene. However, we recently did a survey of patients, and found that only 30% of the patients that we interviewed reported receiving oral hygiene education. So clearly there's a room for even more improvement in this area. And so, what we've done that seems to be quite effective. We placed this poster in patient bathrooms. Brush your teeth to prevent pneumonia. And I would just mention that even though a minority of patients, only 30% of patients reported oral hygiene education. Actually, 0% actually could tell us that the reason we wanted to do that was to prevent pneumonia. So we put this poster in every bathroom. You come in, it's right next to the mirror in the bathroom. Brush your teeth to prevent pneumonia, with a bit of information on why that's important. And we're still looking at the data to see how effective this is, but the initial suggestion is that this is quite effective in getting patients a bit more aware of oral hygiene. And then antimicrobial stewardship, engaging patients in stewardship, we think could be an important way to reduce inappropriate antibiotic use. And clearly there's been a lot of effort to engage outpatients in efforts to reduce overuse of antibiotics, educating people about viral infections as opposed to bacterial infections don't require antibiotics, and so on. So there's a lot of efforts being done outside the hospital, but less has been done in the hospital for patients in terms of stewardship. So this is a study we did, focusing primarily on outpatients as well, but we have a fecal microbiota transplantation program, and the highest risk for failure of the fecal microbiota transplant is when patients receive systemic antibiotics for some other reason. And so what we ask patients to do is to call us if someone tries to prescribe an antibiotic for you. Give us a call, we'll talk to them, or we'll talk to you about whether that antibiotic is really indicated, because often patients are recommended to receive antibiotics that are really not indicated. So during the course of this study, 34% of fecal transplant patients called us, consulted us regarding 43 different antibiotic prescriptions. 60% of those were deemed unnecessary, and of those that were necessary, 16% were felt to be necessary, but there was an alternative that might be less likely to promote, to disrupt the normal microbiota and cause C. diff. So, for example, someone might be trying to prescribe moxifloxacin for a respiratory infection when doxycycline would be an alternative, which is much less likely to cause C. diff. And in this setting, 95% of recommendations were followed. People were comfortable if an ID person was talking to them about antibiotics. The doctors were comfortable following those recommendations. And so the ultimate goal, I've gone through a number of individual things that we can do, but the ultimate goal is to come up with a bundled approach, give people all of these things together as things that they can do to reduce their risk. So here's kind of the visual abstract and poster for empowering patients to prevent HAI. So we would give this information to patients with our goal being, we want to tell patients that all of these things together can help reduce the risk for developing healthcare associated infections. So for promoting provider hand hygiene, you can talk to your providers, or you can get a sign that says, "Thank you for washing your hands." We recommend if you have a device or if someone's prescribing antibiotics, ask, how long do I need this device or these antibiotics? Is it something that's absolutely necessary? If you have a specific infection like C. diff, we would have education about that. Patient hand hygiene, we want to make it accessible. So if you're not able to get out of bed, we provide hand sanitizer. We recommend bathe and change clothing every day. Tell your doctor or nurse if you develop diarrhea, and wear slippers when you're out of bed. And then finally, we've added, since the time we published that, we've added brush your teeth at least twice each day as a bundled way that you could try to prevent HAIs. And there's, others are also working in this same area, typically focus on certain groups of patients. So surgical patient engagement to reduce surgical site infections as a bundled approach is also has been proposed and is being promoted. So here's an expert panel recommendation. This is a group, this is primarily a European group. I think it was published in Journal of Hospital Infection. They've made recommendations how patients can consider all of the things that are recommended to prevent SSIs, smoking cessation, diabetes management, pre-op bathing, kind of putting all of these things together as things that patients can be educated about, keeping warm around the time of the operation, and post-op hand hygiene and wound care. So these are recommendations, and there's evidence that patient engagement can improve chlorhexidine bathing as well. And then these types of bundled patient empowerment initiatives are now beginning to enter into guidelines. So here's the recent guidelines for preventing surgical site infection. In the back of that document, there's a statement, educate patients and families about SSI prevention. Although the quality of evidence is low, these are simple interventions that might help you. And they provide information describing strategies for reducing risk. They give you suggestions of things that you can when you're having surgery, you can pull up all of these things as educational things that you can use, and they're all bundled measures. Here's a recent publication where they piloted different types of educational tools for patients, trying to engage patients in surgical site infection prevention. And then I would just point out, as one of my final points, is that the bundle that I've kind of presented here isn't necessarily the final bundle. We can keep adding things if we find other things or that can be done to reduce risks of infection. So here's just one example that we've contemplated adding into our bundle: avoidance of proton pump inhibitors, which suppress gastric acid. So we should all be aware that our gastric acid provides all of us with an important host defense, and it's not just the acid itself. Nitrates that are produced, bacteria reduce them to nitrites, which produce all these antimicrobial compounds in the stomach, provides a very good host defense, and a lot of acid suppressive therapy, PPIs and other acid suppressive therapy that are received by hospitalized patients are really overused and not necessary. So something that patients could be aware that these types of drugs may not necessarily be benefit and could potentially be harmful. And one other thing which I hadn't thought of either, that one could consider, and that is engaging high-risk patients in efforts to prevent sink drain and other water-associated infections. So this was a recent study published in Infection Control and Hospital Epidemiology, where they actually, so again, these are stem cell patients who are in the hospital for a long time. So this is not short-term stay patients who are at very high risk to acquire infections, including from wastewater. And so the patient was given this splash zone checklist. And so they would go down through and check all of these items. Check there are no items on the counter near the room sink. The sink in the room is being used for hand washing only, not for disposing of other things, et cetera. All of these measures that we think are important to reduce the risk for sink and other waterborne infections. And one of the things on that list is something we've been interested in, and that is the patient, as part of their checklist, is supposed to check off that the water in the sinks is draining well, and there's no backup of water in the sink. So multiple studies have demonstrated that when you get this situation where there's an obstruction in the drain and water starts to back up into the sink, you end up with all of these bacteria that are under the strainer coming up into the sink bowl and splattering out onto the surfaces. So, we actually in our facility did a plumbing intervention to try to remediate these super splasher sinks by reducing the flow rate and making sure that we could eliminate obstruction. And this, again, is something that your high-risk patients could potentially help out with as well. So, in conclusion, our patient still looks very worried. There's a lot of potential risks that this patient is faced with when he comes into the hospital. And so I hope we point out a few, some of these risks and some of the things that the patient potentially can do about that. And then I had this thought a few years ago that one of the things that would be nice to do for hospitalized patients would be similar to when you get on an airplane, where you get on the airplane and everybody's forced to listen to a short, hopefully somewhat fun video asking you to follow the safety features when you're on the airplane. And so I thought in the hospital, we could have something similar, giving patients guidance on what they can do to reduce their risk for infections. So this is a short video that we'll show if it will play, and I will let Paul go ahead and play it.
Hi, I'm Amelia, a member of the care team at the VA. Today, I want to talk to you about staying infection-free during your visit with us. Bacteria and viruses are all around us, so it is important to keep a clean environment. At the VA, your room will be cleaned regularly to reduce the risk for infection. You can do your part by disposing of tissues and other items. Medical devices and physical therapy equipment will be cleaned after each patient use. Talk to your care team if you notice areas that need cleaning. Medications. Antibiotics and other medications that you receive in the hospital can cause diarrhea. Tell your nurse or doctor if you develop diarrhea, which is defined as 3 or more loose or watery stools per day. Wear clean clothing. Your clothing can become contaminated with germs. Notify your care team if your clothing becomes soiled. Be sure to bathe regularly and change into a clean gown every day. Remove devices. Devices like IVs and urinary catheters pose a risk for infection and sometimes remain in place longer than needed. Ask your providers how long devices will be needed and if there's anything you can do to have them removed. Oral hygiene. It is very important that you brush your teeth while you're in the hospital. The germs in your mouth multiply 5 times every 24 hours and can be swallowed into your lungs during sleep, causing pneumonia. You can reduce this risk by brushing your teeth twice a day. Ask your nurse if you need a toothbrush and toothpaste. Hand hygiene. The most important thing everyone can do to stay infection-free is to wash their hands. Viruses like COVID-19 and bacteria can spread by touch, so be sure to wash your hands regularly using soap and water for at least 20 seconds or use hand sanitizer. 4 moments when hands should be cleaned include when entering or leaving your room, before and after touching wounds or devices, before eating, and after using the restroom. Ask for a bottle of hand sanitizer if you can't leave your bed. You can also ask for a sign to be placed in your room reminding providers and visitors to wash their hands. Don't be afraid to speak up and thank them for washing. Take control of your care and help stay infection-free. Just remember the word empower. E. Encourage your care team and visitors to wash their hands. M. Medications. Tell your providers if you develop diarrhea. P. Patient hand hygiene. Remember to wash your hands regularly. O. Oral hygiene. Brush your teeth twice each day. W. Wear clean clothing and bathe regularly. E. Environmental cleaning. Keep your area clean and germ-free. R. Remove devices. Talk to your care team about how long devices are needed. We want your stay to be as short and as comfortable as possible. If you have any questions, please talk to your care team.
Okay, so that that video is loaded in all of the televisions in our facility, and we're currently working to try to get it more regularly seen. But we currently are using this when all of our oncology patients are admitted to the hospital. And so I would just like to close by acknowledging some of the many people who have played an important part in implementing some of these interventions and doing some of these studies. So thank you. I'll be happy to take any questions.
Well, thank you very much, Curtis. That was, as usual, a beautifully framed discussion of how patients can help. And I love the video. Have you had any feedback from patients of how they're viewing that, and are they finding it useful, and what parts are they finding it useful yet?
Yes. So we have surveyed. So we tried we incorporated nursing input when we developed the video, and then also input from patients. So we got their input while we were developing it, and then we've gone out and asked patients, and for the most part, it is very well received. People find it useful, and they do remark that there are some things that they hadn't heard about, oral hygiene and devices and so on. So yeah, we think it's a useful video, and patients seem to like it.
Yeah, I mean, it made a really good point about oral hygiene, and they aren't getting the link. I've been involved in a little bit of work in Australia where we've been interviewing staff, nurses, and patients, and neither seem to be making that as a great connection. So we've certainly got some opportunities there with education. Can I ask you about balancing the fact that we're saying the evidence demonstrates, as you showed beautifully, that patients can disseminate pathogens? Is there any chance that we might stigmatize patients with that or make them feel anxious about their own actions? What's your experience of that? How's that been?
So I have not seen that patients feel stigmatized. And the main thing that we experience is kind of what I mentioned, that patients are worried about transmitting the organism. So, and family members are, and the counter to that is, family members will also ask the same question. Their family member will have, C. diff, and they'll be asking, can I catch this? So it's often important to include the family in some of these discussions, that as long as we follow these measures, it can really make it unlikely that you're going to have any problems related to this infection.
Yeah, I mean, sometimes I think it's almost about the way we frame things and the way people approach something. So say you had a patient in a cubicle and they're colonized with MRSA, do the staff think of this as this is a risk we have to manage for that person, or is this an opportunity for us to work together with the patient to stop them becoming infected with their own organism? Is there that discussion going on, do you think?
Yes, we do try, as part of the discussion, we do try to say this is something bathing is something you can do to protect yourself. So that brings us, I think, to the other thing we would like to do. The video is kind of a general video for anyone admitted to the hospital, but we also would like to make kind of some videos that are specific to, you have MRSA, here's what you can do to reduce the risk that you'll transmit it, to reduce the risk that you'll get an infection, or you have C. diff, you have Candida auris. That, I think, is kind of our next step. We really need, and there are some educational tools out there, but I think we need better tools. And again, I agree with you completely that we want to tell you can do this to reduce the risk that you're going to cause transmission, and not stigmatize.
Yeah, I mean, the problem is, I find, I'm an infection preventionist, and it's getting the language right, and have you got any experience of what language does work well with patients and families without giving them fear of blame, and if not, I mean, who could help us design a good education and empowerment program? Because I'm not a behavioral specialist, or I'm not an educator at that sort of level. Who can help us, do you think?
Yeah, so when we're developing our tools, we try to talk to nurses and to patients, but we have not gone beyond that to talk to people with more expertise in developing simple kind of educational tools that are non-stigmatizing. So
Mm.
involving a sociologist or someone else might actually be of some value in this.
Yeah, I mean, I know, chatting to Dr. David Weber, they have 2 degree or PhD level behavioral scientists in their infection prevention team who
Yeah.
help them out with implementation, and that can work, I think, quite well sometimes. Sometimes I think we're a little bit narrow in our own specialty, and others can help us with their expertise.
Sure.
And you also mentioned that patients don't understand the risks of things like catheters and the central lines and the antibiotics. And do you think why do you think that people don't understand that? Is it because we don't tell them, or is it because of time pressure, or we make an assumption that we know better, or they probably won't understand anyway? I mean, I did a little bit of piece of work years ago looking at why nurses put catheters in, and they never ever disclosed any risk of infection with the patient when they were saying we need to put a catheter in, primarily because they wanted to put the catheter in and they didn't want the patient to push back because they wanted to get the catheter in. So why do you think patients aren't getting the information that they need?
I think that that doctors and providers in general are doing a poor job of providing a balanced recommendation. In the hospital, there's more concern about missing an infection and not giving an antibiotic, and very limited attention to the fact that we gave an unnecessary antibiotic and someone subsequently got a C. diff infection. So, doctors are not penalized in any way for or thinking about the adverse effects themselves, and simply not telling patients the risk has been my experience.
Yeah. I mean, in some ways, surgeons are ahead in that, aren't they? Because they will disclose the risks as part of getting an informed consent. And
Yes.
maybe nurses aren't used to doing that sort of thing. We're going to put you on a ventilator, but there is a chance this may happen. I mean, sometimes it's time constraints, and at the time, the patient may not be amenable to a discussion at that point anyway. Yeah, next question was about hand hygiene, patient hand hygiene, and I really like the 4 moments. Now, we audit hand hygiene in staff to death. Is there a form of audit we might be able to do with patients just to see if they would maybe help better design an educational program that would encourage them to do that? Because I'm struggling to think how you would feed back to a patient group, sorry guys, your hand hygiene is all terrible, you're nearly as bad as the doctors. That probably wouldn't work quite so well.
Yeah. We, for some of our studies, we've given patients bottles of hand sanitizer and measured the amount of alcohol that's being used. And that's a simple way that we measure, staff hand hygiene sometimes as well. But that is a good question. How else can we measure patient hand hygiene? I'm open to suggestions.
Yeah, well, I mean, I have done a little bit of observational work when we were interested, like you, of putting in some hand wipes, and especially things like before eating, because that patients touch everything, and C. diff and gram negatives get into the body through 1 or 2 ways. They either go the top entrance or the bottom, and it's generally the top. So we were interested in getting the hand hygiene better. So we did actually have somebody sitting observing, and then we gave them the wipes, and it seemed to get better. But you'd have to have a really good reason to expend the time, I think, to be able to do that.
Yeah.
Another thing I wanted to ask is, along the audit line, if you're going to encompass a patient activity in a bundle, then probably you ought to measure if they're doing it or not. And does that then give the staff actually the responsibility was the patient, so we shouldn't get penalized with the bundle here. The patient themselves didn't do their shower, possibly because they didn't have the capacity or the motivation to do it. Now, how could we support this empowerment without putting responsibility onto patients?
Yeah, I think that staff and patients, I still think we can make it important for staff to document that patients have performed the appropriate measures, and if they haven't, then they need to be documenting what they're doing to deal with it. So if the patient hasn't done their chlorhexidine bathing prior to coming in, this staff member is going to have to document why that was and what they can, how they can.
Yeah, I mean, because that's useful information, isn't it? Once you start learning, if there's a theme here, they're not doing it because, then there is a barrier there. And I'm just wondering, what other barriers do you think that you've found in your context? Is it access to products, or the staff not prompting, or some cultural issues, possibly, potentially, anyway?
So it's both of those. I think staff are not. It's not part of their routine to prompt patients. Make sure that you're using the hand sanitizer, and then lack of access to products is number one. I think a lot of patients are not getting out of bed, and they just simply they don't have hand sanitizer. We find that for oral hygiene, patients, some patients are not even aware that they receive a bag of supplies for oral care. And some patients are not even aware that they received that. They missed that, and it's sitting in a drawer somewhere. Which I actually remember one other thing, that when you ask about, how we might monitor whether patients are complying, we do have one thought that we're trying out with oral care. So there actually is a electronic tool you can use to monitor, that people use this to monitor whether their children are brushing their teeth. It's called the truth brush, where it records whether the child has used the toothbrush. It can pick up the motion. And so one could do something similar for patients. And if the nurse could then see that the patient did not brush their teeth, they can then go and say, do you have a toothbrush? What do you need? So maybe there are some other types of high-tech ways that we could help monitor.
I like that. I like that very much. The truth brush. Yeah, very good. I mean, because it's getting people to recognize that there's been an admission, and people almost, I think, in nurses sometimes look at oral hygiene as quite fundamental care, but they would almost rather have the patient's skin clean to freshen them up than do their mouth. And I've found that when patients are mobile, then it's absolutely thought it's the patient's responsibility to make sure they've done their teeth. And it's having these little prompts, isn't it? And having some data locally to say, actually, this unit is actually their oral hygiene is markedly worse than other people. So is there something cultural we can do here?
Yeah.
Well, it's been absolutely fascinating. Thank you so much for this. It's very stimulating. I think there are enormous opportunities for partnership with patients and to make things a lot better. I've really enjoyed this session. Thank you so much. Well, everybody, we come to the end of 2025, or nearly there. And just to point out that 2026 will be a celebration of 25 years of the teleclass education, started in 2001. And I need to thank Paul for his dogged perseverance and his ability to twist arms of speakers from all over the world, because many speakers have come and stayed and continue to give many, many lectures. And I would also urge you to have a little look back through the recordings library, because there's a lot of history there, including many speakers who sadly are no longer with us, but their wise words, which are often still very relevant today, are still available for us. And it's just worth a little walk down memory lane occasionally. It only fails me to say, look forward to next year's teleclasses. We have some exciting speakers lined up. The program isn't quite out yet, but it will be available shortly. But we have teleclasses in January will feature John Otter and Professor Pramit Seth, who I know works in Queen's University in Ontario, I think, and probably it's a microbiome related session in that one. Finally, just to thank the teleclass education patron sponsors, Diversi, Virox Technologies and Gamma Healthcare, without whose support it would be difficult to put on this fantastic teleclass series. Thank you again, Dr. Donskey. Been a fantastic session. I look forward to your session next December, because I know you've already confirmed that you will be happy to do that. And I wish everybody happy holidays and a happy 2026. Thank you for joining us.